We've got a session now on upper GI bleeding. I think that's very important for everyone across the world, really. It's a problem that's going to present to the hospital sooner or later, and I think you need to know how to deal with it. We've got a range of approaches to this. We're going to look at the scope of the problem, who's doing what. We're going to look critically at the guidelines, and we're going to have some theory about how we go about treating this.
The talk is about the scope of the problem, no pun intended. So the scope of the problem of why is that rebleeding rate, and between those two numbers, I won't give you the exact number, why is it that we cannot get that number down to zero? Is it because the endoscopic therapy is simply not good enough, or is it because of some other unwarranted variation? So the objectives of this lecture are to identify those factors, to talk about them, because getting it right first time saves lives. But then maybe there's an elephant in the room. Now, just take a little time to look at this elephant. He's really beautiful. He's red, blending into the background. There's someone, I'll take it that the endoscopist is this young lady here. So she's not looking at the elephant. She's looking up here. She's looking, if you will, permit me, through the elephant. She's looking at scope technology. She's thinking about what technique she can get out of it. She's thinking about putting her over the scope clip on because she likes to do that. She's thinking about when she needs to get out of bed to come and do the endoscopy, but she is not thinking about the elephant. And she's not we are, as I think, a group of people who think about this problem, not particularly considering the issue of inter-endoscopist variation.
And once the bleeding is stable, you can halve the dose after 1 day. Classically, this is continued for 5 days, but if the bleeding is less severe, 2 days may be sufficient too. Then antibiotics also very integral, important in cirrhosis. For every upper GI bleeding, you consider a prokinetic agent like erythromycin. And then early endoscopy, this is called early. Actually, the Baveno guidelines suggest within 12 hours of presentation for variceal bleeding, so that's an urgent endoscopy. Or even sooner, if your patient is really unstable, doesn't get stable despite volume resuscitations, despite the vasoactive treatment, maybe even a bit earlier. Then, of course, as we all know, for an acute esophageal variceal bleeding, endoscopic variceal ligation is a recommended form of treatment. And for gastric varices or gastroesophageal varices type 2, so the one extending to the fundus, tissue adhesives such as histoacryl are the way to go. And for the gastroesophageal varices type 1, the one extending into the lesser curvature, you can choose between the two. So this is the classification. The last 3 tissue adhesive, and the first one you can choose between a tissue adhesive and an endoscopic variceal ligation.